A 69-year-old man named Raymond came to me 3 months after completing treatment for early-stage colorectal cancer. His surgery had gone well, his oncologist was cautiously optimistic, his follow-up scans were clear, and Raymond was doing what most people do in that window after treatment ends. He was trying to get back to normal. He was eating the foods he had always eaten. He was returning to the routines that felt familiar and comforting. He was, as he put it, just trying to live his life again. What Raymond did not know, what nobody had sat down and explained to him clearly in the weeks after his treatment, was that one specific thing in his daily diet had been documented in peer-reviewed cancer research as a direct fuel source for the very type of cells his body had just spent months fighting. He was consuming it every single day, not in vast quantities, in the amounts that most people in this country consume it without a second thought, in the amounts that appear in almost every packaged food on a standard supermarket shelf, in the amounts that his breakfast, his afternoon snack, and his evening dessert collectively added up to every day without his knowing. And no one had told him that this needed to change, because the oncology appointment covers the treatment. It does not always cover what feeds the disease between treatments. That gap is what I am here to close today. What I am going to share with you is not a miracle cure. It is not a claim that changing one food will prevent or treat cancer. I want to be precise about that from the beginning, because precision matters more in this conversation than in almost any other. What I'm going to share is what the published science says about how cancer cells obtain their energy, which dietary compound most directly feeds that energy system, and what the evidence tells us about reducing that compound in the diet as part of a broader approach to reducing cancer risk and slowing the proliferation of cancer cells in people who have already been diagnosed. This is a conversation about biology, about how the disease works at the cellular level, and about one specific dietary change that the evidence supports with more consistency than almost any other nutritional intervention studied in oncology to date. If honest, evidence-based health information is what you are here for, please subscribe right now and hit the like button. Every week, I bring you the clinical conversations that do not always happen in the appointment room. This is one of the most important ones I have made. I am Dr. Kevin Adewale. I have worked in internal medicine and oncology support for over 30 years. I have sat with hundreds of patients at various stages of cancer diagnosis and recovery, and the question I am asked most consistently, more than any question about medication, about surgery, about treatment protocols, is this one. What can I eat and what should I stop eating to give myself the best chance? It is the right question. It is the question that deserves a specific, evidence-based, honest answer. And today, I am going to give it to you. Before I name the food, I need to explain the biological mechanism that makes this conversation necessary. Because without understanding what cancer cells actually do with food, how they feed themselves, how they grow, how they differ metabolically from healthy cells, the food advice sounds like another wellness claim. With the biology behind it, it is something entirely different. It is actionable science. In 1924, a German physiologist named Otto Warburg made an observation that would eventually win him the Nobel Prize in Physiology and Medicine. He noticed that cancer cells behave very differently from healthy cells when it comes to how they produce energy. Healthy cells generate energy through a highly efficient process called oxidative phosphorylation. They take glucose, burn it in the presence of oxygen inside their mitochondria, and produce a large amount of energy very efficiently. Cancer cells, Warburg observed, abandon this efficient process even when oxygen is plentiful. Instead, they revert to a far more primitive and far less efficient method of energy production called aerobic glycolysis. They consume glucose rapidly, process it without full oxidation, and produce energy at a fraction of the efficiency of a healthy cell. To compensate for this inefficiency, cancer cells consume glucose at a rate that is many times higher than any healthy cell in the body. Some research estimates that cancer cells consume glucose at 10 to 50 times the rate of the normal cells surrounding them. This is not a fringe theory. This is not alternative medicine. The Warburg effect, as it is now called, is one of the most extensively studied and consistently confirmed observations in all of cancer biology. It is the biological basis for PET scans, the imaging technology used in oncology to detect cancer anywhere in the body. A PET scan works by injecting a radioactive glucose molecule into the bloodstream and then imaging where in the body glucose is being consumed at the highest rate. Cancer cells light up on a PET scan because they are consuming glucose faster than any other tissue in the body. The entire diagnostic technology is built on the fact that cancer cells are glucose hungry in a way that is measurably different from every healthy cell around them. The question this raises, and the question that Raymond had never been asked to consider, is straightforward. If cancer cells are consuming glucose at many times the rate of healthy cells, and if the glucose available to those cells is determined by what we eat and drink, then the amount of rapidly absorbed glucose we introduce into our bloodstream every day is directly relevant to the environment in which cancer cells are either thriving or struggling. This does not mean that removing all glucose from the diet kills cancer cells. Every cell in the body needs glucose, and complete glucose restriction is neither safe nor achievable through diet alone. What it means is that the specific form of glucose that arrives in the bloodstream fastest, that causes the sharpest, highest, and most sustained spike in blood sugar, provides the most immediately available fuel for the cancer cell's preferred metabolic pathway. And that specific form has a name. The number one food feeding cancer cells daily is added sugar. Not the sugar naturally present in whole fruit or whole vegetables. Not the glucose your body produces from complex carbohydrates after hours of digestion. Added sugar, specifically refined sucrose and high fructose corn syrup, added to processed foods and drinks, which causes the sharpest and most rapid rise in blood glucose of any dietary compound, and which delivers that glucose directly and immediately to the bloodstream in the form cancer cells are most equipped to consume. Let me be precise about what this means in practice, because the phrase added sugar sounds manageable until you look at where it actually lives in the average diet of a person over 60 in the UK or the US. It is in the breakfast cereal that carries a Heart Health logo on the box. It is in the flavored yogurt that is marketed as a healthy snack. It is in the fruit juice that is described as one of your 5 a day. It is in the granola bar that replaced the biscuit. It is in the low-fat salad dressing because when manufacturers remove fat from a product, they replace it with sugar to maintain palatability. It is in the bread, the pasta sauce, the flavored oatmeal, the sports drink, the vitamin water, the shop-bought soup. Added sugar is not a category of food that most people eat deliberately and knowingly. It is a compound that has been inserted into the majority of packaged foods in quantities that accumulate across the day without the person consuming it being clearly aware of what they are taking in. The average adult in the United States consumes approximately 77 grams of added sugar every day. The World Health Organization's recommended limit for adults is 25 grams per day, less than a third of the average actual intake. And for people over 65, whose insulin sensitivity is typically reduced, whose blood sugar regulation is less efficient, and who are statistically most likely to be living with or beyond a cancer diagnosis, the gap between what is being consumed and what the evidence supports as safe is widest and most consequential. Here is what the research says specifically about the link between added sugar consumption and cancer. A landmark study published in PLOS Medicine followed over 100,000 adults over a period of 5 years and found that higher consumption of sugary drinks and foods with high added sugar content was significantly associated with increased risk of several cancers, including breast cancer, prostate cancer, and colorectal cancer, after controlling for overall caloric intake, body weight, physical activity, and other confounding factors. The association was not explained by obesity alone. The sugar itself, independent of its contribution to weight gain, was associated with elevated cancer risk. The mechanism proposed by the researchers was direct. Chronically elevated blood glucose and the resulting chronic hyperinsulinemia, the persistently high insulin levels produced when the body constantly manages large glucose loads, promote cellular proliferation and suppress the normal apoptotic signals that tell damaged or abnormal cells to die. Cancer cells, already proliferating abnormally, benefit from both the glucose fuel and the proliferative signaling environment that chronically elevated insulin creates. A separate analysis published in the British Journal of Cancer examined dietary patterns in cancer survivors and found that high added sugar intake was associated with significantly elevated markers of systemic inflammation, C-reactive protein, interleukin-6, and tumor necrosis factor alpha, all of which are known promoters of cancer cell survival and tumor microenvironment development. The inflammatory environment created by chronically high sugar intake does not cause cancer cells to appear, but it creates conditions in the surrounding tissue that make it easier for existing cancer cells to survive, to evade immune surveillance, and to proliferate. And a study published in Nature Communications specifically examined the relationship between dietary sugar, the insulin-like growth factor signaling pathway, and cancer cell proliferation. It found that IGF-1, a growth hormone whose production is stimulated by insulin, which is in turn stimulated by blood glucose spikes, directly activates the growth pathways inside cancer cells that drive tumor expansion. Every time blood glucose spikes sharply, insulin rises sharply in response. Every time insulin rises sharply, IGF-1 rises in response. And every time IGF-1 rises, it activates precisely the growth signaling pathways that cancer cells use to divide and expand. This is not a theoretical pathway. It has been measured, replicated, and confirmed across multiple cancer types and multiple independent research groups. Raymond was consuming, by his own account, approximately 60 to 70 grams of added sugar every day. His breakfast was a bowl of flavored granola with low-fat flavored yogurt and a glass of orange juice. His afternoon snack was 2 digestive biscuits with tea. His evening dessert was a small pot of flavored rice pudding. Each of those choices on its own would not raise alarm in a standard dietary review. Together, they were delivering a daily glucose load that was keeping his blood insulin elevated for a significant portion of the day, providing abundant fuel for any remaining cancer cells his immune system had not yet cleared, and maintaining the inflammatory signaling environment that cancer cells exploit for survival. Every single day. Now, I want to address something directly because I know it will be in the mind of some people watching this. Does reducing sugar intake cure cancer? No. Is reducing sugar intake a substitute for medical treatment, for chemotherapy, for surgery, for the guidance of an oncologist? Absolutely not. Is there a single dietary change that will guarantee cancer does not progress or return? No, and anyone who tells you otherwise is not giving you honest information. What the evidence supports is this. Chronic high added sugar intake creates a metabolic and inflammatory environment that is demonstrably more favorable to cancer cell survival and proliferation than a low added sugar environment. Removing that advantage from cancer cells by reducing the glucose spikes that fuel them, the insulin spikes that signal them to grow, and the inflammation that protects them from immune surveillance, is a meaningful, evidence-supported, risk-reducing action that costs nothing and carries no side effects. It is not a cure. It is removing an advantage you have been unknowingly giving to the disease. Let me now give you the specific, practical actions that translate this understanding into something you can do starting today. The first action is to spend 1 week reading the nutrition labels of every packaged food you currently eat. Not to count calories, to find added sugar. Look for the words sucrose, glucose syrup, high fructose corn syrup, maltose, dextrose, maltodextrin, fruit juice concentrate, and cane sugar in the ingredients list. These are all added sugars operating under different names. Any product that lists one of these in the first 4 ingredients contains a significant added sugar load. Write down what you find, not to judge yourself, to see clearly what you are actually consuming versus what you believe you are consuming. For most people, this exercise produces genuine surprise. The gap between perceived sugar intake and actual sugar intake is consistently larger than expected. The second action is to identify and replace the 3 highest sugar items in your current daily routine, not all of them. 3. The breakfast cereal, if it contains more than 5 grams of added sugar per serving. The flavored yogurt, which typically contains 15 to 20 grams of added sugar per pot, replaced with plain live culture yogurt with fresh berries. The fruit juice, any fruit juice, including fresh squeezed, replaced with water or herbal tea, because fruit juice removes the fiber that slows sugar absorption and delivers the sugar load of 3 to 4 pieces of fruit directly into the bloodstream in the time it takes to drink a glass. These 3 substitutions alone, made consistently, can reduce daily added sugar intake by 40 to 50 grams for the average person, bringing intake close to or within the WHO recommended range from a starting point that may have been 3 times that level. The third action is to restructure meals to slow glucose absorption, even when some carbohydrates are present. This is not about eliminating carbohydrates. It is about the order and combination in which food is eaten. Research published in Diabetes Care demonstrated that eating vegetables and protein before carbohydrates at the same meal reduces the post-meal blood glucose spike by up to 37% compared to eating the carbohydrates first. Eating fat and protein alongside carbohydrates slows gastric emptying and blunts the glucose peak. Ending a meal with a small amount of apple cider vinegar diluted in water, a practice with emerging evidence from 2 small clinical trials, has been shown to reduce post-meal glucose spikes by improving insulin sensitivity at the cellular level. These are not dramatic interventions. They are adjustments in the pattern of eating that reduce the height and duration of every blood glucose peak your body produces after eating. The fourth action is to specifically reduce or eliminate 2 sugar delivery systems that most people never think of as sugar. The first is alcohol, specifically beer, sweet wine, and spirits mixed with sugary drinks. Alcohol metabolizes through the liver in a way that disrupts blood sugar regulation and promotes the same insulin and IGF-1 signaling environment as direct sugar consumption. For someone who has had a cancer diagnosis or who has strong family history of cancer, alcohol's contribution to both hormonal cancer promotion and systemic inflammation is disproportionate to the quantity consumed. The second is low-fat products of any kind. Low-fat products routinely replace their fat content with added sugar to maintain palatability. Low-fat salad dressing, low-fat yogurt, low-fat cereal bars, and low-fat breakfast products frequently contain more added sugar per serving than their full fat equivalents. The marketing language and the biological reality are operating in opposite directions. The fifth action is to bring this conversation to your GP or your oncologist at your next appointment. Specifically, ask for your fasting insulin level to be measured alongside your fasting glucose. Most people over 60 have had their fasting glucose checked. Far fewer have had their fasting insulin measured. Fasting insulin is the number that tells you whether your body is maintaining chronically elevated insulin levels in response to your current dietary pattern. An elevated fasting insulin is the direct hormonal driver of the IGF-1 signaling pathway that promotes cancer cell growth. A fasting insulin level above 10 micro-IU per milliliter is considered elevated in most clinical guidelines, and levels above 15 in the context of a cancer history or family history warrant specific dietary intervention and discussion with your clinical team. This number is available from a single blood draw. Ask for it. I want to come back to Raymond. After our conversation, Raymond made the changes I have described. He replaced his breakfast entirely. Plain oats with no added sugar, topped with blueberries and a spoonful of almond butter, with water or black coffee rather than juice. He replaced his flavored yogurt with plain yogurt. He stopped the evening dessert and replaced it with a small handful of walnuts and 2 squares of dark chocolate above 85% cocoa content, which contains minimal added sugar and contains compounds, specifically flavonols, that have been associated with reduced inflammatory signaling in multiple studies. He did not follow a complicated diet plan. He identified the highest sugar items in his daily routine and replaced them with alternatives that served his body's needs without feeding the cellular pathway that had already cost him a surgery. At his 6-month oncology review, His fasting insulin, which had been 18 at the time of our first conversation, had dropped to 9. His C-reactive protein, a marker of systemic inflammation, had halved. His oncologist noted the change and asked what he had done differently. Raymond told him, and his oncologist said what many oncologists say when this conversation comes up: "I should be telling every patient this. I just do not have the time." That is precisely why this channel exists. Not to replace your oncologist, not to offer you an alternative to medical treatment, to fill the time that the appointment does not have, to give you the biological understanding that makes a dietary change something you do because you understand why, not because someone told you to. Raymond understood why, and understanding why is what made the change sustainable rather than temporary. The cancer cell is extraordinarily good at surviving. It adapts, it evades, it finds ways to persist in environments that should eliminate it. But it has one fixed metabolic dependency that it cannot adapt away from. It needs glucose. It needs it in large quantities, and it needs it delivered rapidly. Every time you flatten a blood sugar spike, every time you choose a food that digests slowly rather than one that floods the bloodstream immediately, every time you reduce the insulin surge that signals cancer cells to grow, you are making the environment inside your body slightly less hospitable to the disease. Not once, not dramatically, consistently, daily, over months and years. And consistency is where biology changes. If this video gave you something that changes what you put on your plate tomorrow morning, share it with the person in your life who is currently going through treatment and has never been told what to stop eating, with the one who recovered and went straight back to the diet that may have contributed to the diagnosis, with the one who is not currently ill but who is over 60 and consuming 70 grams of added sugar a day without knowing it. This information belongs to them, and you sharing it may be the most important thing they hear this year. If you have not yet subscribed to this channel, please do it now and hit the like button before you leave. Every week on this channel, I bring you exactly this kind of conversation, evidence-based, clinically grounded, and honest about what the research actually says as opposed to what is comfortable to say. Subscribe so you receive it before you need it. One final and essential point. Everything in this video is general health education based on published peer-reviewed research. It is not medical advice, it is not a treatment protocol, and it is not a substitute for the guidance of your oncologist, your GP, or any other clinician managing your care. If you have a cancer diagnosis, please do not make significant dietary changes without discussing them with your clinical team first. Some cancer treatments interact with dietary patterns in ways that require professional oversight. This video is the beginning of an informed conversation with your doctor, not a replacement for it. Take it to your next appointment. The biology I have described is real. Your clinical team can help you apply it to your specific situation. That is the right order. Education first, clinical application with professional support second. Always. Take care of yourself. You have more influence over the environment inside your body than you may have been told. Use it.